This is the first in a series of talk about pediatric EEG. It will be conducted in two sections, a conversational and a question and answer section. The statements in this frame are fundamental concepts in the interpretation of EEG in general, but particularly when interpreting a pediatric EEG. Few single findings render an EEG abnormal, and many questionable activities are better considered normal unless they fit with the clinical findings. When uncertain about an EEG arises, ask, repeat the study after sleep deprivation, or do a longer EEG. But whatever you do, do not establish abnormality without there being one. So, no doubt, reading EEG is art, but also science. The art you will learn with time. The science you will learn with effort. So let's start with the effort part. Calling an EEG normal includes confirming the presence of age-appropriate frequencies for behavioral awake state, finding the normal frequency amplitude relation, encountering a symmetric background, encountering background synchrony, not finding lack of reactivity to eye closure after 6 months of age, finding age-appropriate obligatory graphoelements, and establishing the absence of abnormal graphoelements. This later principle often implies not mistaking normal graphoelements for abnormal ones. I will, in this conversational section, address each of these previously stated principles individually. So let's start talking about appropriate frequencies for the awake state. And I will do so by introducing to you this article. This article was published in 1949. This article is certainly not an easy read. In it, you find an even more complicated figure, which you can see in this frame. Somehow, someone deciphered all that information, and the result of this deciphering was introduced by Class in his classic book, Current Practice in Clinical Neurophysiology. It was introduced in the form of columns according to frequencies in the different regions of the brain, matched with age in different rows. This chart has been duplicated in many textbooks, including Fish EEG Primer, and it is the source of many questions that will come up in your exam. One thing to notice in this figure is that the electrodes were not labeled according to the 10-20 system that we're used to. This system was obviously not used by the authors back then. Instead, the electrodes were labeled as frontal, parietal, and occipital as I have colored in this figure. It was with these parameters and this arrangement that the chart you are now seeing was constructed. The first time I saw this chart was in the class book I previously mentioned. This chart is complicated, but I hope to make it less so in the next few frames as I build it up from scratch. In this frame, you are seeing 3 letters. The letters are the initial for each region. Pointed by the arrow, you can see x per second. A row of wave per second will be constructed for each region in the next few frames. In this frame, I have added a column representing different ages. Now, pointing by the arrow is the 1 to 3, which indicate 1 to 3 wave per second. The cream column represents the site of intersection between rhythm constituted by wave occurring with a frequency of 1 to 3 per second and age. The size of the circles represent the relative amount of the given activity, in this case of the 1 to 3 cycle per second activity. So a relative larger amount of delta activity, that is activity in the 1 to 3 Hertz range, is present during the first 30 days of life, and hardly any will be present at 9 years of age. The same general mechanics can be used to comment on the relation between 4 to 6 cycle per second activity and age, but obviously with different results. As you can see in this new column, 4 to 6 per second activity peaks at 2 to 3 years of age, and again at about 14 years of age. Activity with a frequency of 7 to 9 cycle per second peaks in the frontal lobe at about 4 years of age. Activity in the 9 Hz range is maximal in the frontal lobe between 4 to 16 years of age, whereas activity in the 10 Hz range in the frontal area appears at about 1 year of age, increasing during childhood, and this increase is sustained during adolescence. A similar trend occurs with activity of 11 Hz, but starting a little bit later at about 3 years of age. Finally, low voltage irregular activity also has a similar pattern, but starting at about 10 years of age. The parietal region also goes through the changes that are reflected in this master chart, and so does the occipital region. This chart that I have just introduced is a summary of the information from the previous master chart. I have included in it what I consider the most relevant information. I will also build it from the ground up in the following frames to make it more understandable. It conveys the criteria for abnormal proportionality in the awake patient. On the left column, the activity are divided into delta, theta, alpha, and beta. Delta implies wave from 1 to 4 per second, theta from 4 to 7 per second, alpha is restricted to activity from 8 to 12 per second, and beta any activity faster than 12 per second. So any delta activity after 10 years of age in the frontal region, 9 in the central or parietal region, and 8 in the occipital region is abnormal. So as you can see, this chart works by using the word under quality, in this case any, to fill the space label Q as pointed by the arrow, and then the number below each region to fill the blank space before year. I hope that during the next pass you will find this clearer. So, prevalence of delta activity after 1 year of age in the frontal lobe or region, prevalence of delta activity after 1 year of age in the central region, and prevalence of delta activity after 1 year in the occipital region is abnormal. Any theta activity after 19 years of age is abnormal in all regions. Prevalence of theta activity after 7 years in the frontal region, after 4 years in the central region, and after 3 years in the occipital region is abnormal. No alpha activity after 1 year is abnormal. Not a prevalence of alpha activity after 8 years in the frontal region, 5 years in the central region, and 4 years in the occipital region is abnormal. No beta activity after 10 years in the frontal region and after 11 in the central and occipital region is abnormal. It is important to stress that these parameters are the conclusion of one individual based on my interpretation of a figure that was drawn from information presented in a paper written in 1949. So, contradictory conclusions could have been drawn at many steps along the road. I will point out some of them in the next few frames. The next step in declaring an EEG normal is finding the normal frequency amplitude relation and also documenting their symmetry. This chart attempts to summarize absolute amplitude and frequency relation as well as side-to-side relative proportionality. As I did in the last chart, I will again build it from the ground up in the hope that it would be more understandable. Under normal conditions, there is a direct relation between frequency and amplitude. Waves that last longer have higher amplitude than those of shorter duration. This results from the same reason that compound muscle action potentials, their wave being the product of a slower speed conduction through the muscle fibers, are wider and taller than those that are generated by sensory nerve potentials. As you can see, I have added under activity the different categories found in regular EEGs. Delta activity should be no higher than 100 microvolts. An asymmetry of more than 50% is abnormal. Theta activity should be no higher than 100 microvolts too. And as with delta activity, an asymmetry above 50% is considered abnormal. Alpha activity of less than 15 microvolts measured from T5 to O1 is mentioned as abnormal in Fish primer book. That is so if found in children between 3 and 12 years of age. At other ages, amplitude is not considered abnormal based on its amplitude in this book. An alpha asymmetry of above 50% is considered abnormal by all. Everson books qualify beta activity above 25 microvolt as abnormal, but it adds that it is not clinically significant. In Fish book, a beta activity asymmetry of more than 35% is considered abnormal. Most other books require 50% asymmetry as for any other frequencies to be called abnormal. After finding a normal frequency amplitude relation, the next step in the course of declaring an EEG normal is to encounter a symmetrical and synchronous background. Background symmetry and synchrony is usually determined by Gestalt. Asynchrony of the background activity between hemispheres indicates poor hemisphere connections. After finding synchrony between the hemisphere, the next step to label a pediatric EEG normal is not to find lack of reactivity to eye closure after 6 months of age. Infants go through great developmental changes during the first year of life. Between 1 month and 12 months of age, they go from laying down to walking. In the first 3 months of life, an EEG of an infant may capture awake, drowsy, and sleep periods. Most of the awake period, because of the discomfort of the electrode placement, will produce an unreadable tracing. Brief periods of quiet awake are sometimes present, and the technician should take advantage of them. This advantage should be to close the infant's eye during those periods of quiet wakefulness. During the first 3 months of age, closing the eyes of an awake infant does not trigger a change in EEG activity. Once the first 3 months have gone by, at the 4th month of age, a same operation will lead to significant EEG changes in the occipital lobe. This is the EEG of a 4-month-old infant with eyes open. Now the eyes are closed, and as you can see, the EEG becomes higher voltage and better organized in the occipital region. This activity will reach at this age a frequency of about 3 to 4 Hz. Next in the order, in the orderly process of determining an EEG as normal, we will need to find age-appropriate obligatory graphoelements. This includes spindles and, to a lesser degree, K-complexes. Consider them obligatory if the record represents or presents with features consistent with a sleep stage 3. Another obligatory graphoelement is a posterior dominant rhythm appropriate for age. Spindles evolve through time, which I have represented as a green line starting at 1 week and ending at 1 year of age. At 1 week, some rhythmic activity with some resemblance of a spindle are usually found, but they cannot be called spindles because they do not last half a second, which is a criteria to diagnose a spindle. These wannabe spindles are asynchronous and asymmetrical. Spindles with a duration of at least half a second and with a frequency of 14 Hz first appear by 2 months. They tend to be biphasic without spindle configuration. They are also asymmetrical and asynchronous. By 3 months, they are still biphasic and monomorphic and are very long. They last as long as 10 seconds. They are also asymmetrical and asynchronous at this age. By 5 months, they become shorter and have a monophasic quality. The waves constituting them are sharper on one side than on the other. They are still asymmetrical, but usually synchronous. They have a negative feel at the parasital area. Their synchronicity still is far from being 100%. By 1 year, they are still monophasics and they are short. But at least 70% of them are symmetrical and synchronous. By 2 years, they turn biphasic and symmetry and synchrony is present in 100% of them. By 3 years, they become even shorter, and according to Hugh books, at 5 years, 12 Hz spindles appear that persist till the teenage years. In Lure's book, not shown in this frame, they describe the presence of 12 Hz spindles occurring in 5% of children until the age of 12 in the frontal region. They mention that these spindles last less than 3 seconds. The other obligatory graphoelement, perhaps not as obligatory as spindle, is K-complex. As I previously stated, I consider the presence of K-complex or spindle, one of the two of them, as obligatory graphoelements only in cases where the EEG is run until evidence of a stage 3 are present in the recording. K-complexes first appear at 4 months of age. Rudimentary K-complexes may appear before that. K-complex may become repetitive following a stimulus by about 8 months of age. They are largest between 5 and 15 years, and then they become lower amplitude and slower as time goes by. The other graphoelement that I consider obligatory in a recording with periods of alerting, opening and closing of the eyes is age-appropriate alpha rhythm. There is a significant controversy as to what indicates age-appropriate for alpha rhythm, but at this point I will only give one set of normal, which is that a posterior dominant rhythm with a frequency of 8 is normal at 8 years of age. Once the presence of obligatory graphoelements in the correct setting are documented, the next step is not to mistake normal graphoelements for abnormal ones, and for the normal graphoelements to have the correct distribution. This will be discussed in the following section. This section will be conducted using a question and answer format. So we finished the conversational segment and we're about to start the question and answer format. The first question is, which of the following is not true regarding spindles? A. Longer at 4 months than at 4 years. B. Synchronous and symmetrical after 2 years of age. C. Frontal 12 Hz spindles after 5 years of age. D. More than 50 microvolt from C3 to A1. By 5 years, the frequency of some of the spindle may be 12 Hz, and they are of short duration and frontal localization. These slow spindles are not found after 12 years of age, according to some authors, although others describe them well into the late teenage years. So the answer to this question is D. Next question. K complexes are largest in older children and early adolescent. A. True. B. False. As you can see in this frame, K complexes are largest in older children and early adolescents. So the answer to this question is A. True. Next question. Most infants' EEG first show an occipital dominant rhythm as early as dash of age. A. 2 months. B. 4 months. C. 6 months. D. 12 months. During the first 3 months of life, shutting the eyes of an awake infant does not produce any changes in the background activity over the occipital region or anywhere else in the scalp. After 4 months of age, the background activity changes when the eyes are covered. This is the same EEG tracing that I showed you before. As you can see, with the eyes open, the background is disorganized. This is happening at an EEG recorded at 4 months of age. Once the eyes are closed, an organized occipital background activity reaching about 3 to 4 Hz appears. So, no reactivity after several artifact-free trials in a 6-month or older infant is abnormal, but if it is the only abnormality, I tend to dismiss it because of the uncertainty in the testing. So the answer to this question is B. Next question. In a 3-month-old, the fastest activity during wakefulness normally predominates in the dash region: A frontal, B central, C temporal, D occipital. During a wake, in the first 3 months of life, the predominant activity is central. Central activity is considered by some to be a precursor of mu rhythm. This is an example of what I just mentioned. This tracing is of a 3-month-old infant during a wake. As you can see, the predominant activity is in the left central region and also in the right central region. This was noted in the 1949 frequency chart Notice that in the frontal region, from 3 months to 9 months, there is hardly any activity that reaches 4 to 6 Hz. Neither is there any such activity in the occipital region. But the central region has a fair amount of it. So the answer to this question is B, central. Next question. The central region hosts the fastest EEG activity until the age of dash years: A1, B2, 3C, D6. At 1 month of age, the activity arising from the brain in the frontal region is very slow, hardly reaching 4 to 6 Hz in a very, very small amount. The same is true in the occipital lobe. Much faster activity, and especially much more of the 4 to 6 Hz activity, is found in the central region. At 6 months, the fastest activity, or the prevalence of the fastest activity, is also in the central region. At 1 year, it's the same. At 2 years, the same. There's more fast activity in the central region than in the frontal or occipital region. At 3 years, still the fastest activity is encountered in the central region. That is, the fastest amount of fastest activity is found in the central region. But by 4 years, the fastest activity is found in the occipital area. So the answer to this question is C. Next question. Nighttime sleep consolidation is usually present as early as dash years of age: A2, B4, C6, D8. This chart depicts sleep, naps, and awake time in a 24-hour period at different ages. As you can see, at 1 month there are 5 sleep periods. One tend to be larger than all the others, but not necessarily occurring during the nighttime. During 6 months of age, there are 3 sleep periods. There are 2 sleep periods by 3 years of age, and by 4 years, the sleep period is consolidated to 1 nighttime sleep period. So the answer to this question is B. Next question. Actively closing the patient's eye by the mother or person doing the EEG is the best method to elicit posterior dominant rhythm until years of age. A2, B4, C6, D8. In the first 3 months, shutting the infant's eye do not produce any EEG changes. By 4 months, most of the time, it does. As you can see, and I have already shown you in this tracing. By 7 months, when the eyes are open, the posterior activity is disorganized and of lower amplitude. When the eyes are closed, as you can see in this frame, in multiple occasions, the posterior activity becomes more organized. The same occurs at 14 months of age and at 18 months of age. The same is also present at 2 years of age, but at this time, the child will cooperate and movement artifact will occur because of the discomfort of closing the child's eyes for the child. And at this age, a cleaner record is usually obtained by playing monkey see, monkey do, and the examiner closing their eyes themselves in hoping that so does the infant or the child. At this time, the activity frequency is usually 6 to 7 Hertz. So the answer to this question is A. Next question. The posterior dominant rhythm of a 1-year-old should at least be Hertz. A 6 to 7, B 8 to 9, C 10 to 11, D 11 to 12. The frequency of the posterior dominant rhythm is an important pediatric EEG parameter. The posterior dominant rhythm first appears at 4 months of age. At this time, it appears with a frequency of about 3 to 4 Hertz. By 6 months, the prevalent frequency is 5 Hertz. From about 9 months to about 18 months, the prevalent frequency is 6 to 7 Hertz, 8 Hertz. The lowest adult limit is usually achieved by 3 years of age. And the term alpha rhythm is often used instead of the term posterior dominant rhythm at this junction. So the answer to this question is A. Next question. The amplitude of the ongoing occipital activity of a 9-month-old boy has a higher amplitude when his eyes are closed by the examiner than when his eyes are open. A true, B false. The amplitude of the occipital lobe rhythm is less important than its frequency. Nevertheless, it has some characteristics that are worth mentioning. With eyes open, the occipital activity at 3 to 6 months of age usually range from 10 to 20 microvolts, and from 7 months to 12 months it doubles. The amplitude of the posterior dominant rhythm, that is of the rhythm in the occipital area once the eyes are closed, increases. At about 3 months, it is from 50 to 100 microvolts, and by 9 months, the usual amplitude is 100 to 200 microvolts. So the answer to this question is A. Next question. Please take a look at this frame and decide whether the activity here presented is normal or abnormal. To answer this question, first look at the montage, especially at the area of question. Then notice the scale that is being used. Then look at the activity of question, which in this case is the activity at the level of the occipital lobes. Notice that this activity has a frequency of about 8 to 12 Hz and has a fluctuating quality as it would be expected when the activity is due to alpha rhythm. If you recall the criteria for abnormal amplitude that we stated in the past, alpha activity amplitude has no upper limits of normal, and an asymmetry is abnormal only if it is over 50%. So the alpha activity in this patient is normal. And the answer to this question is A. Next question. Please take a look at this epoch and decide whether it is normal or abnormal. You start by looking at the montage. It is a common reference montage to the ipsilateral ear. And then by noticing the activity in the prefrontal region, as well as in the frontal region. Notice that the activity in these two areas is more prominent than the activity at the occipital region. You can see that pointed out by the arrow in this frame, and also notice that the activity in the occipital region is faster than the activity in the frontal region. See that the activity in the occipital region is 8 to 10 Hz and a relatively high amplitude, while the anterior activity is in the 6 to 7 Hz range, but is also of very high amplitude. Going back to the chart for the criteria of abnormal amplitude, we have to look at the theta rhythm. Notice that theta activity has an upper voltage limit, which is 100 microvolts. So the answer to this question is B. The lower limits of adult posterior dominant rhythm frequency is usually reached by dash years of age: A2, B3, C4, D8. The frequency of the posterior dominant rhythm is an important pediatric EEG parameter. At 4 months, it first appears, as we have previously mentioned. At that age, the frequency is 3 to 4 Hz. By 6 months, the prevalent frequency is 5 Hz. From 9 to about 18 months, the prevalence frequency is 6 to 7 Hz. At 3 years of age, the posterior dominant rhythm is about 8 Hz. This is the lower adult limit. So remember, most but not all children reach 8 Hz posterior dominant rhythm by about 3 years of age. Now, it must also be stressed that not reaching it does not imply an abnormality, since still a significant number of normal children do not reach that posterior predominant rhythm frequency. So the answer to this question is B. Next question. A posterior dominant rhythm of at least 8 Hz must be present in normal children by as early as years of age. A2, B3, C4, D8. Significant discrepancy exists among different books regarding when the posterior dominant rhythm of less than 8 in a child should be called abnormal. I will first quote from Levine and Luters. As you can see in this chart, months and years are in the x-axis and hertz in the y-axis. The aqua line represents the frequency in relation to age. At 3 months, the posterior dominant rhythm, when found, is about 3 Hz. At 1 year, in 70% of children, the posterior dominant rhythm reaches 6 Hz. At 3 years, the posterior dominant rhythm is 8 in 80% of children. Ebersol books presents a more complicated set of values. The chart here presented is only expressed in years, but the text provided in the book allows you to take into account months. So at 3 to 4 months, the posterior dominant rhythm consists of poorly sustained 4 Hz activity. That is so in 75% of healthy full-term infants. At 1 year, 6 Hz is attained in 70% of the cases. At 3 years, a mean frequency of 8 is usually present. That is 8 Hz. This is attained in 82% of children. By 9 years, 9 Hz mean alpha is present in 65% of normal children. And by 15 years of age, 10 Hz is reached by 65% of healthy teens. Class complicates things even more by presenting the data using the term of 95% confidence. The line in green is the lower range. Following this chart at 1 year of age, most children have reached a posterior dominant rhythm of 7. By 3 years, most have reached 7.5 Hz. And by 5 years, the posterior dominant rhythm continues to be about 7.5 Hz. That is the lower limit of the posterior dominant rhythm. By 8 years, not all have reached 8 Hz. Hughes' book, EEG in Clinical Practice, makes it very simple. It established that less than 8 Hz by 8 years is abnormal. So the answer to this question is D. Next question. Which of the following produces slowing of the posterior dominant rhythm? A. Early encephalopathy. B. Phenytoin at therapeutic levels. C. Carbamazepine at toxic levels. D. All of the above. Alpha activity is considered any rhythm with a frequency between 8 and 12 Hz, regardless of its timing and location. Alpha rhythm, on the other hand, is a rhythm with a frequency between 8 to 12 Hz found in the posterior regions that appears in the weak patient with eye closed and is blocked by eye opening. This is the most sensitive activity produced by the brain. So the answer to this question is D, all of the above. Next question. When can an EEG be labeled abnormal just because of a too low posterior dominant rhythm amplitude despite normal frequency? A, never. B, always. C, from 3 to 12 years of age. D, after 21 years of age. Most would say never. Ebersol book says that 6 to 7% of normal adults have a posterior dominant rhythm of less than 15 microvolts. In Fish EEG primer, it states that a PDR rhythm of less than 15 microvolts when measured from T5 to O1 at the age of 3 to 12 years of age could be abnormal. So the answer to this question is C. Take a few seconds to look at this epoch and decide whether the abnormal side is the left or the right. Left is on top and right on the bottom, as recommended by the Academy of Neurophysiology. The patient is blinking, but the eyes remain open after the blink. In a subsequent epoch, the eyes are closed. Notice the better organization of the posterior dominant rhythm on the right. So the answer to this question is left. The left side is abnormal, but I do not think that anybody could tell just by looking at the first epoch I show you without seeing subsequent epochs. Next question. Which of these two tracing is abnormal? A, tracing number 1, B, tracing number 2. This question can be initially simplified by asking yourself, is tracing 1 is normal or abnormal, and if tracing 2 is normal or abnormal. When judging an activity in the posterior electrodes, always look for eye movement artifacts. Here you see that after eye blinking, the posterior activity becomes disorganized. Hence, the activity preceding can be labeled as predominant rhythm. In this case, we are dealing with a posterior dominant rhythm consisting of posterior slow waves of youth. Notice the configuration of the wave inside the green box. Here I have enlarged it. Now let's look at the second EEG. Again, look at the wave inside the green box. Notice its configuration and the preceding and following electrical activity. But more importantly, notice that the change and disappearance of the wave with eye opening. This is characteristic of benign occipital seizure of childhood. So, analyzing this question, we can reach the conclusion that the second tracing is abnormal, whereas the first one is normal. So the answer to this question would be B. Next question. Any delta activity in the occipital lobe of a 9-year-old without alpha rhythm characteristics is abnormal. A true, B false. This is the general chart that you have been seeing throughout this talk. As you can see, at 9 years of age, no delta activity should be present in the occipital lobe. This is a slightly different presentation of the same data. Regarding delta activity, any delta activity in the occipital region after 8 years of age is abnormal. So the answer to this question is true. Next question. Except in the dash lobe, a significant increase in the proportion of theta activity occurs from 13 to 17 years of age during wakefulness. A frontal, B central, C temporal, D occipital. This is again going back to the master chart that I have been showing you through this talk. As you can see, from 13 to 17 years of age during wakefulness, a resurgence of theta activity occurs at the frontal and parietal region. But this doesn't happen in the occipital region. So the answer to this question is D. Next question. At 6 years of age, theta activity is most prevalent in the dash region. A frontal, B central, C temporal, D occipital. Theta activity should not be the prevalent activity after 3 years in the occipital lobe, nor should it be the prevalent activity after 4 years in the central region and after 7 years in the frontal region. Thus, it can be prevalent at 6 years only in the frontal region. So the answer to this question is A. Next question. After dash of age, delta activity should not be the prevalent EEG activity during wakefulness. A. 1 year, B. 2 years, C. 3 months, D. 4 years. This chart is regarding the criteria for abnormality. As you know, because you have seen it many times before, delta activity, prevalence is abnormal after 1 year of age in the frontal, central, and occipital region. So the answer to this question is A. Next and final question in this section. An asymmetry of 40% in dash activity may be considered abnormal. A. Alpha, B. Beta, C. Theta, D. Delta. Beta activity in Fishbook is described as abnormal if there is an asymmetry by more than 35% between hemispheres. I am introducing this frame at this junction to show you the effect of unilateral skull trepanation on beta activity and also on eye movement. The green arrow points to eye movement in the opposite side of the trepanation, and the magenta arrow points to the eye movement on the side of the trepanation. Notice that the eye movement on the side of the trepanation is smaller. In this new frame, the yellow arrow points to the beta activity on the opposite side to the trepanation, and the magenta arrow to the beta activity on the side of the trepanation. The beta activity on the side of the trepanation is bigger. It is over 50% bigger. So the answer to this question is B. Thank you very much for your attention.